This brief online learning is about detecting and managing delirium in intensive care. Delirium is an acute, fluctuating, confusional state. There are two main types, but some patients present as a mix of the two types. One type is the withdrawn type or hypoactive delirium. The patient is withdrawn, they show slower psychomotor function, they appear lethargic, withdrawn, confused, not particularly with it. They have a reduced awareness. They can't concentrate or pay attention. They may not be verbalizing, but they will probably be experiencing in the background delusional beliefs such as paranoia and feeling that staff are out to get them. They may believe that they're somewhere other than the hospital, and they're likely to be having nightmares or wakeful hallucinations. Be careful with this type of delirium because it's often misdiagnosed as depression, and antidepressants given in the case of delirium are likely to prolong the period of delirium. The other type that's easier to spot is hyperactive delirium or the agitated type. Again, the patient struggles to pay attention and can't consistently organize their thought, so are likely to be nonverbal. But if they are verbal, they're likely to be confusing in what they're saying, perhaps shouting out, pulling at lines, being restless, hard to settle. And again, they will be experiencing hallucinations, delusions, and potential fearful paranoia. Both patients are disorientated. To understand some of the psychological components of delirium, it's important to remember that when your patient comes into intensive care, their body and mind are in a state of acute emergency. That's stress, lack of control, fear, and insecurity. But what's going on in their body, as well as the disease or injury process, is poor sleep, an inability to speak, a feeling of isolation and loss of body integrity, and general overwhelming fatigue and bodily tension. These psychological and physical components together give the person an altered temporary body state. It's hard for them to relax, concentrate, and believe that we are doing the best we can and are a safe pair of hands. Patients often will struggle with their sleep wake cycle when desedated and will go into mini sleeps or hypnagogic states. Those patients who are sedated will experience sedation withdrawal, which can lead to delirium. All in all, it causes this temporary, confused, disorientated space. Initially, patients' lack of contact with reality and sense of unreal experiences can activate the fight or flight. The patient becomes aggressive and agitated. Over time, fear and horror set in, and the patient withdraws to take care of themselves. So they feel exhausted with resignation, and that's hypoactive delirium. Some patients go straight to hypoactive delirium. Here are some of the causes: that lack of sleep or sleep wake cycle, sepsis and infection, metabolic and electrolyte disorders, alcohol and drug withdrawal, hypoxia, and sedatives. So many of our patients in intensive care are likely to experience delirium. The knock on effect is that they will experience higher mortality, a longer hospital stay, and of course, then an increase in healthcare costs. Patients who survive are likely to go on to have psychological trauma as a result of their delirium. Any acute distress that they experience in delirium in the ICU is a strong predictor of psychological outcome post ICU. So it's important that we look out for delirium in the ICU. Assess your patient for delirium using the CAM ICU. Please watch other videos about how to use the CAM ICU assessment. In the non pharmacological management of delirium, rather than going straight to drugs to manage any agitation or withdrawal, we need to think about what's causing the delirium and manage the physical causes. Assessing with CAM ICU means that we monitor for signs of delirium. Targeting sedation and documenting RAS is also thought to help with minimizing delirium. Thinking about the patient's sleep wake cycle and managing their environment so that they are awake in the day and asleep at night is key. Orientating the patient when desedated, helping them to feel safe and reminding them they're in hospital, working with the patient to goal plan, engaging their family, and talking to the patient consistently, carefully responding to any signs of hallucinations and delusions. We encourage wakefulness during the day through that orientation, but also through making sure the blinds are up and the patient has access to daylight. You may even consider turning their bed where possible. There should be light conversation and age appropriate music in the background, but think about keeping the noise to an easier level because the patient may become quickly overwhelmed and may withdraw. Where possible, getting the patient to sit up, move, sit out, and potentially over time putting the patient in their own clothes will help. And as the patient starts to recover, encourage them to regain their independence and lead their own care. Thinking about nighttime, we want to promote good sleep hygiene at night for all patients. So, where possible, keep the unit to a bedtime routine. Turn down or out the lights. Reduce the noise as much as possible and cluster your care. Think about physical contact with the patient because it will impact how the patient experiences you and how safe they feel. So it's a good idea to say the patient's name as you approach them for any procedure, explain what you're going to do each time, try where possible to approach from the front, and try some initial light touch, such as the back of their hand or their shoulder, as you're starting to indicate that you're going to initiate physical contact. Where possible, beware sudden movements, beware approaching the patient's face without initial verbal or physical contact, and avoid sudden touching or grabbing. And where possible, think about the people around the patient and avoid crowding them. All patients with delirium are likely to be experiencing delusional beliefs and hallucinations. Sometimes these are positive, but quite often they're negative and they're paranoid. Many patients won't even tell you. But where possible, try to acknowledge and validate that the patient may be feeling scared or alone. Reassure them that they're safe, that it's common to see and hear things that are not there. Sometimes telling them that this is what patient experiences may mean that a patient will tell you what's on their mind. But it's important to reassure them that this is a temporary thing that will pass. Where possible, try not to argue with the patient. It's likely to make no difference to their delusional belief and is more likely to mean that they won't trust you, or they will withdraw from you, or they will fight with you. Be careful about being dismissive, laughing at the patient, or telling them off for how they feel. The patient's likely to feel invalidated and distrustful. We keep ICU diaries in critical care as a way of helping the patients post critical care make sense of their experiences. And a lot of the time, this is about making sense of what happened when all they can remember are their delusional and delirium experiences. Remember, the key is to help your patient feel emotionally safe as well as physically safe. Think about what comfort you can offer them. Is there anything you can tell them to help them with a sense of certainty? Offer them a sense of choice. Think about communicating at all times and keeping the intensive care a calm and, where possible, predictable environment. Thank you.